Hello, everybody. If I asked you what the biggest drivers of falls in care homes are, most people would say medication, muscle weakness, maybe poor vision. Very few would actually say feet. Yet the evidence is absolutely clear. Foot pain, loss of sensation, deformity, or poor footwear are directly linked to increased falls, reduced mobility, increased pain, loss of independence, and ultimately poorer outcomes for care home residents. Half of care home residents fall every year. Many fall more than once, and we know falls accelerate frailty, increase hospital admissions, drive deconditioning, and in many cases mark the point at which someone never quite recovers. What's even more uncomfortable is this: foot health in care homes is largely unregulated. There are no clear national standards. Anyone can call themselves a foot care provider, and many managers understandably assume that if someone turns up offering foot care in a care home, that they must be qualified. Result is that something which should be basic clinical prevention is treated more like a beauty service. Toenail trimming instead of clinical assessments, short-term fixes instead of long-term prevention. And the cost of that? Pain that goes unrecognised, reduced walking, increased fear of movement, higher falls risks, pressure injuries, ulcers, in diabetic residents, even the increased risk of amputation and mortality. Yet the flip side is equally powerful. Good foot care improves comfort, improves gait, improves balance. It improves confidence and helps people to stay mobile for longer. This is not cosmetic care. This is preventative healthcare. Today, I'm joined by two clinicians who have tried to tackle this one specific part of the problem in a very practical way. David and Heather are podiatrists and founders of Kaydiar, the team behind the product called Zerosol, developed specifically to address pressure-related foot pain and prevent some of the most common problems we see in older people's feet. So rather than just talk about foot care as a problem, they tried to build a solution. So Heather and David, welcome. So Heather, would you like to introduce yourself?
Yeah, hi everyone. I'm Heather. I'm a podiatrist. I'm also a co-founder of Kaydiar Limited, which is a company that specializes in pressure relieving technology, where we develop the product Zerosol. And I do also practice clinically as well as a podiatrist in Hywel Health Board NHS Trust.
Fantastic. David?
And just following what Ed said, yeah, I'm David Barton, podiatrist by trade and also the co-founder of Kaydiar, and I head up the R&D side of Kaydiar Limited and do a lot of the in-house testing around product development.
Fantastic, thank you. So before we get into kind of products and solutions, can you just paint the picture for us? So when you walk into a care home, what are you actually seeing in terms of foot health?
Yeah, so we see a range of issues that often go unnoticed. It's very common to see residents with excessively dry skin, which can be a sign of endocrine issues such as diabetes, or we might see overcrowded toes due to deformities, essentially. That can make basic hygiene quite difficult. We often see signs of poor circulation too, but perhaps most commonly we see results of pressure, things like corns, calluses, and in more severe cases, ulcers that have developed from those particular precursor lesions, simply because of a resident has lost sensation in her feet and hasn't been able to fill the damage that's occurring because of high levels of pressure.
Thank you. And do you think that most care home managers genuinely realise how much foot pain affects day-to-day life of care home residents?
I think it's quite possible that this is underestimated. We do often hear patients say, for example, their foot pain does prevent them from moving as much as they might like to. We know that foot pain does directly impact general mobility. When someone's feet hurt, they simply just don't want to walk around quite as much. It's not just a foot complaint, it can be a significant barrier to their physical independence as well.
You listed a lot of the sort of the common issues, David, with sort of dry skinned, potentially for diabetes and corns, calluses, poor circulation, ulcers. I mean, these can have a real impact. But what does foot pain actually look like in practice? How does it really show up in behaviour of residents?
Quite often. So how I would see it show up would be either sort of a withdrawal or a reluctance to walk altogether. As just an example, I see quite often that if someone does have a sore foot, so whether that's a resident or a patient in practice, either due to deformity, corns, calluses, or perhaps fat pad atrophy, we do see that these people either become fearful of movement altogether because they can't avoid that pain when they're walking, or in some cases, if they do still have that good level of mobility, they may have to actively adapt their walking pattern or how they're sort of placing their foot down. And this in itself can be very challenging and quite effortful, particularly if it is an older person or resident who might already have other joint and mobility issues. So that in itself can look like challenging behavior, or in some cases it might be perceived as laziness, but it's often just due to the fact that that contact with the ground will trigger their pain.
Yeah, makes for uncomfortable listening, to be honest. And we talk a lot in social care about falls prevention. And it's something that we at Care England are really focusing on at the moment. But so how strong is that link between foot health and falls really?
So the evidence is quite strong. Peer-reviewed trials and data from NHS improvement show that preventative podiatry interventions like proper footwear checks and footwear or foot exercises can reduce falls by as much as 36%, which is really significant. When you consider that half of care home residents fall every year, addressing foot health is one of the most effective ways to tackle this statistic.
I mean, mobility is a real issue, isn't it? 36%, that's a very significant reduction in falls. I mean, falls are one of the leading causes of mortality in older people. So in terms of mobility, kind of more broadly, if someone's feet hurt, what tends to kind of happen over time? How does that progress and mature?
So the first sort of stage that we might see, particularly if that person is mobile enough to be able to adapt their walking pattern, for example, to avoid the area, the first thing we might see is compensatory pains. So this would lead to a gradual decline in mobility as those compensatory pains progress over time. So if they're struggling to walk, they may be using other muscles and structures a lot more and relying on those structures. Once this occurs, or if they were not fortunate enough to be able to avoid that pain in the first place, then they would stop moving altogether. As we know, keeping residents mobile is critical really for maintaining that quality of life. So if you do have painful conditions underneath the foot, you would naturally avoid walking, and over time that would lead to those compensatory mechanisms and a decline in general health and well-being over time until those soft tissue structures become stiffer, and then eventually would potentially lead to more restriction and deformity as well.
And it's those compensatory pains are where the body naturally compensates to take the pain away, but then that causes the problems elsewhere, and you're sort of pushing the problem around the body, and you have to correct lots of things. I know that from personal experience. So I think it's probably fair to say that unresolved foot problems can quietly accelerate deconditioning of residents. Do you have any sort of thoughts on that?
Yeah, definitely. I agree. It almost creates like a cycle. So that pain leads to immobility, and then that immobility leads to muscle weakness and deconditioning. So residents who might have remained active for many years suddenly no longer can walk about, and they become quite sedentary because of something as treatable as like a basic corn or callus even. This also increases dependency on staff. Residents with foot pain or ulcers require around 20 to 40% more care at time, which well, compared to those who might not need that additional time and care.
And when we talk about deconditioning, we talk about frailty, and I don't want to be too morbid here, but you know, we often think about mortality, and we think about that in terms of like the big medical events. But for someone living with frailty and deconditioning, that loss of mobility could be the beginning of the end, can't it?
It can, yeah. So in particular, diabetic residents specifically, foot health is critical. There is an increased risk of amputation and mortality associated with the diabetic foot and diabetic foot ulcers. But even generally, falls, which cost care homes between 3 to 5K per incident, often mark the point where a resident never quite recovers their independence. Prevention isn't just the comfort, it's about preserving life and independence, essentially.
And you said falls are costing 3 to 5K as well, but actually when you scale that up across all of the care services, so social care costs the system about £1.1 billion a year, according to some quite old data now. So, you know, it's a huge cost for the whole system to bear. Thank you for sharing that. I think let's just talk a little bit about your story, though, because your story is sort of really quite interesting. So tell me about how the two of you actually got into kind of zero soul and podiatry, because this started as a university project, didn't it?
It did, yeah. So this was back in 2017 as a dissertation project. So Heather and myself would often go into the staff room cupboards in the manufacturing labs in podiatry, and we'd see a lot of issues with the current kind of legacy products. You know, there would be very short fixes. They weren't really suited for long-term chronic problems such as like corns, calluses, and diabetic foot ulcers. They were very much quick gimmicky solutions that were pre-packaged but nonetheless weren't effective for the long run. So we wanted to go out there and really design something that was a good offloader for pressure. We focused on pressure, and we focused on the diabetic foot, ulcers in particular, and we used that as a kind of point for our dissertation project. Luckily, we managed to get rent-free premises because obviously my parents coming over from Kent, we had a place where we could use that money, which otherwise would have been spent on rent. We used that to invest in 3D CAD software and 3D printers to make our first prototypes, which proved to be quite successful. So we were spurred on from the university. They trusted their faith in us to make this into a business. They funded our patents in exchange for some stake in the company. And then following that, we then blossomed and moved on, getting rewards, quite lucky to get some rewards and quite investment to grow the company.
And I know you said there around, you know, the frustrations with the sort of short-term solutions and what have you. And yeah. I think the diabetic foot side of things really interested me because I read a statistic recently that around sort of 70% of people in residential care could have some form of diabetes or pre-diabetes. So actually, you know, and the foot is one of the early signs of people who don't necessarily have a diabetes diagnosis that you might start to see things change, eyes and feet. So for me, it was a real kind of flag to say we need to be doing more about raising the profile of kind of feet generally and how important they are for older people. But what was it that frustrated you about the solutions that already existed?
I suppose in terms of the diabetes side of things, again, it kind of just goes back to that sort of short-term issue in terms of the prefabricated sort of off-the-shelf devices that are available. So modular foam-based insole products were the sort of main port of call for an active wound, but the issue is that these wounds, you know, the average lifespan of a diabetic foot ulcer is 12 weeks, and these particular foam-based insoles typically last around 2 weeks because of their construction and that compression that happens very quickly with these foam type materials. In terms of the other side of what we're looking to target, which is those precursor lesions, such as corns and calluses, even in people that are not diabetic, current existing products again are quite short term. They are made of mainly sort of felt-based products that you might stick onto the foot. So these would need to be applied every day. And also one of the main things that really frustrates me, to be honest, as a podiatrist, is these salicylic acid plasters and these sort of acid-based treatments, which can be quite damaging to the skin, particularly the healthy skin. And in those which are quite vulnerable, so older people with diabetes, that could easily trigger off an ulcer as well. So that's probably my biggest frustration, is these active products.
And it's those ulcerations that then really become very difficult and challenging to heal. And then you are spending your time potentially deconditioning because people will stop using the feet to weight bear and what have you. So you're kind of compounding the problem. So at what point did you realise that this could be more than just a student product, that this could really genuinely help people?
So we wanted to produce a product that wasn't just clinically effective with, through studies and watching what was going on in the labs. We wanted to also look at accessibility, affordability, and a device that could be used over a long period of time, therefore increasing cost effectiveness. When we saw we could create something that could allow healthcare workers to issue something immediately without specialist equipment, we knew this could change how healthcare professionals and even care homes could manage foot pain.
Just to add as well, it's also the fact when we started doing the project and we were getting some data back from the pressure redistribution and what sort of offloading capability we could achieve with just an early stage prototype, that was also a big factor in when we thought that this could progress into something a lot more, exciting and something that we could bring to market.
No, I was introduced to you by someone that we both know, another partner of Care England, and I've always struggled with my feet. I do find I do when I have to do the Care England shows and I've got 8 hours stuck on my feet, I struggle. And I was very kindly sent one of your products and I used it and I was just blown away how I could just be up there, and I suffer with back issues as well and I wasn't doing that compensatory side of things, and it really made a huge difference for me. But so I know the product and I love it and I've got it in my shoes currently. But for someone who's kind of watching who isn't potentially clinical, what is Xerosol in simple terms?
So actually, I'm planning to actually do a demo for you guys. I will just explain Xerosol in simple terms. So Xerosol is an easy to use customizable insole. So it sits inside the shoe to take pressure away from painful or high pressure areas such as corns and calluses. So it's made of shock-absorbing silicone. It has removable components, or removable cells, as we call them, and has a soft memory foam layer to cushion the blow onto the foot. So for those who have lost that protective padding, such as elderly individuals, dry skin, this can be a really effective solution for those painful spots on the foot. And just to give you guys a little demo. So this is the Xerosol. It will come in this box, and inside the box you will have double-sided stickers which you can then place onto your lesion. So taking my hand, for example, thinking that this is the foot, you'd place it onto your lesion on the foot. Once that sticker's on there, you would then lay the insole on the ground, you'd step over the insole, that sticker would transfer onto the black top cover fabric, so you'll see a white sticker on that fabric. And then what you do is you just simply take up the floor, you would press it forward, and you would know roughly what parts to take out. So I've done this prior to this, but that would be an example, a common site that you want to kind of take out these little components. And if I get close enough to the camera, you can see how I'm just tugging on that, and you can see how that white area is now starting to sort of peel that component away. So as we said, no equipment, just simply grab, tear, and then you get your effective offload for about a good 6 to 8 months, which is very cost effective.
Fantastic. I mean, it really is a superb product. But what problem is it actually solving that traditional insoles or padding don't solve?
Yeah, so traditional padding compresses and stops working after a short period of time. So it comes back to that, quick fix, gimmicky kind of arena that we've seen a lot of in podiatry through over-the-counter products, or stuff that's just in the stock cupboards, which hasn't really worked before for other patients. So sometimes these things, it could last hours. In some cases, it can last days, but nonetheless, it's sort of not a long-term solution for these chronic conditions. Generic cushioning insoles as well often miss the specific problem area entirely. So with Xerosol, it's designed to target and zone in on those high pressure areas to relieve that pressure, to actually tackle the cause of the problem, and provide something long lasting. Like I said, 6 to 8 months is what it can offer. So it solves the problem of long lasting pressure relief, which is what is needed to stop corns and other foot problems from returning.
Long-term relief for long-term problems, because these problems aren't fixed very easily. So it's not a short-term fix for a long-term problem. And so I think when you show these sort of the little hexagonal cells, putting those off, you know, the idea of removing those to offload pressure is really interesting. But why does that matter clinically?
Clinically, most of these conditions, so corns, calluses, even neuropathic ulcers under the sole of the foot, they are typically caused by pressure. So removing those specific hexagonal cells under that high pressure point, we aren't just cushioning the foot, we are physically reducing that pressure, that harmful pressure under that problem site. So if you remove that pressure, you treat the root cause of the injury rather than just managing the general symptoms.
So you've seen evidence of foot pain reduction when people are using your products even before treatment in some cases. So why is that important?
You know, there's going to be many scenarios where, say, a resident or someone has a painful corn or callus. Xerosol can help to alleviate that pain immediately, even prior debridement. So if there is a wait to have a podiatrist or someone come in and do that called debridement part of the treatment plan, they will be comfortable in that period of time when they're waiting for that person to come and debride that lesion. And also it just you know, it's great giving that immediate pain reduction to keep that resident moving as well in that period of time.
And that's what's important, is that once we stop the mobility, we start to decondition, frailty takes over, and it's a slippery slope down. And we tend to accept that as the norm within adult social care. It happens because a lot of the older people we care for are towards end of life. So some services, some people might be expecting that that's just a normal state of progression. But actually what we're saying here is that there are individuals who are still capable of mobilising. We can slow the rate of deconditioning. We give them better quality of life while they're still with us. So these are really important things to look at, and we shouldn't dismiss the fact that someone is preferring a more sedentary position because they might have foot pain. We need to understand that and really take time. And non-registered professionals coming in giving foot advice is really dangerous for us, isn't it? So in terms of the product, how can care homes access the product? Is it available on prescriptions, FP10s, or is there a website they can navigate to understand more? Because I'm sure there's a lot more we haven't covered today that you probably would like to tell us.
Yes. So care home residents or family members can get Xerosol reliever directly from us on our website and receive that within a couple of days. We have a lot of educational podiatry content on our website, so zero-sol.com. That's where you can get a lot of that content from, which shows how to use and customize Xerosol. And we have a contact us page, which we man directly ourselves as well, so you'll be able to talk to podiatrists. So there are routes that you can go through. We are working with the FP10 right now. We're nearly there. We're right to the end stages, so eventually it will be on prescription, and we're also on the NHS supply chain through our partners as well.
Fantastic. So this is product recognised by the NHS, which I think really helps us with the kind of the clinical credentials. If you were speaking to maybe a care home manager directly now, you know, watching or listening to this, what would you want them to rethink about foot care?
So I think we would ask them to move away from seeing foot care as just hygiene or toenail trimming. It needs to be seen as a preventative intervention. Simple things like daily foot checks, checking for sensation, feeling pulses, and using simple things like emollients can prevent major issues from occurring. It's about being vigilant, spotting a red mark or hard skin before it becomes an ulcer or even more of a major problem.
So I picked up on the daily foot checks there. So that's something that we need to be thinking about, is looking at people's feet on a day-to-day basis, identifying what's changing, making notes and speaking. So what we talked about today, is this about replacing podiatry or is it about strengthening podiatry outcomes?
Yeah, I see it definitely as like a sort of a collaborative working together situation to strengthen our overall outcomes. We know podiatrists, well, we are essential really for debriding any wounds and hard skin and managing complex conditions. But unfortunately, podiatrists can't be within the care home setting every single day. So this is where we feel that having those proper care protocols and preventative elements will help empower staff to maintain those, you know, the foot health in between podiatry visits, and creates like a complementary approach, if you like, where the day-to-day management supports the podiatrist's overall clinical treatment and outcome.
I think just adding to that, you know, when you've got professionals talk to professionals, things aren't separated and segmented. When things are more integrated and there's good communication, you get naturally better health outcomes.
And a lot of care homes don't have podiatrists going in at all. And a lot of them don't have a podiatrist in every day. So it kind of needs to be complementary, doesn't it? They need to complement each other. And we as care providers need to take on board different sort of behaviours to kind of monitor foot health, and then to speak to the podiatrist to get the best sort of feedback and solutions. So where would you see kind of the solution that you offer, Xerosol, practically fitting in on a day-to-day basis? Is that sort of with comfort, falls prevention, resident pain? Where would you see it fitting in?
We see it does fit into all three areas, but more specifically the pain management and comfort aspect, because we are providing that shock absorption for conditions like fat pad atrophy, pressure relief for corns and calluses, but we're reducing pain essentially to then improve stability and mobility, and that's where the sort of falls prevention area comes into. So practically, we are trying to reduce the burden on staff as well by preventing foot issues and reducing the total care workload that's put in place once a problem has occurred.
So if care homes really take foot care seriously as part of clinical kind of governance and sort of the daily foot checks that you talked about, what difference do you think we would see sector-wide?
Financial and human impact would be massive. So for medium-sized care homes, just by implementing, a Xerosol or a preventative measure alone, could save care homes between 175 to 320k annually. We would see fewer falls, fewer hospital admissions for ulcers, essentially, and a workforce that is less stretched because they aren't spending 20 to 40% of their time caring for and preventable foot complications, essentially. So the impact would be quite massive.
Oh, so I mean, there's some very significant numbers there. So there's a real opportunity for care homes to reduce costs whilst improving the quality of life for those that we care for, and those benefits become systemic as well, because the NHS will save a lot of money in terms of reducing the amount of falls that people have, reducing the treatment costs related to pressure ulcers, which can have a real issue and be incredibly difficult to kind of manage, maintain and treat for people. The numbers speak for themselves. There is an opportunity to do something here for care homes, but also for the NHS. What would you say kind of worries you most when foot problems are ignored?
I would say it's that definitely sort of like the silent damage, if you like. So for people with neuropathy, if they step on a pin or debris and they don't feel it, or if that isn't spotted because shoes aren't checked or feet aren't looked at, it becomes essentially an infected ulcer. So that then can lead to the amputation risk and the significantly higher mortality risk as well. This is a worst case scenario, but it's something that is entirely preventable.
Yeah, I mean, it's definitely something you don't want to ignore. But have you seen cases where something has started as just a bit of foot pain but led to something far bigger? Because I think that's what we need to do, is to try and help people understand that something that starts as small pain could be actually something much more significant.
Yeah, we see cases where a small corn left unmanaged, for example, becomes a chronic wound, like an ulcer. We see residents who stop walking because of painful corn or calluses, and that mobility can lead to severe falls or rapid frailty. So losing that mobility is a big issue, and it's rarely just foot pain. It's the catalyst for something much wider, or a decline in their health. So these are like kind of signs that we need to pick up on.
From a corn to a wound, the catalyst for something more significant. And you said before, Heather, about potentially, certainly in diabetes, it can lead to amputations, which, and everything potentially can lead to, a negative impact on mortality. So look, thank you very, very much to both of you today for taking the time to kind of share your experiences with us. I think today's conversation has been really helpful and helped to highlight that foot health isn't peripheral. It's central to dignity, mobility, safety, and also, care home residents' quality of life. There's a clear message to care home managers who we know are under extraordinary pressure already, and nobody is suggesting adding yet another burden to their workload. But sometimes improvement doesn't come from big system-wide changes. It comes from paying attention to the things that we've normalised in our sector for far too long. And foot pain should not be normal. Falls linked to preventable cause should not be inevitable, and residents losing mobility because no one looked closely enough at their feet should not be accepted. So David and Heather, again, thank you so much for your time today. And to everyone watching or listening, if this has made you look differently at foot care in your services, then this conversation has done its job. Thank you very much.
Pleasure. Thanks, Aaron.
Thank you.